but also I think more importantly about the actions that we've taken and actions still to take to ensure that the service is safe for our women and babies, but also is the right environment for our staff as well. So back at the beginning of the year, we did report 6 incidents as a cluster, and these were of babies that were sent out for cooling. That is the right thing to do for those babies, but that did trigger a responsive review from the CQC. We had proactively reported these incidents to the CQC, and they came in and did a responsive review back in June. They issued us a warning notice subsequent to that, and they rated the service inadequate. Now, clearly, that's not a position as a trust we want to be in. I just want to emphasise this is just the Basildon site. It's not Southend and Broomfield. They did, however, on that inspection also note that there were improvements that had been made, and they came back in September to do a revisit of those improvements. And again, they noticed some improvements had been made, but there were still some issues that needed resolving. Now, I thought it would be helpful just to talk you through some of the issues that they had found. But before I do that, I think it would be helpful just to put into context just a little bit about maternity services. So particularly at Basildon, we haven't seen an increase in the number of births. That's remained pretty static over the last 3 or 4 years, to be quite honest. But what we have seen is an increase in the risk factors of our women that are delivering here, particularly in terms of obesity, diabetes. They're the 2 main risk factors that we are seeing an increase in, and that, of course, increases their risk in terms of delivery and increases their acuity as women coming in to deliver. And we have seen, corresponding to that, an increase in our caesarean section rates. I think also it is important to note that whilst we have obviously a number of improvements to make, what we're not being reported as an outlier in terms of stillbirths, perinatal mortality, any of the national position at the moment, we're not being viewed as an outlier. So what the issues they found, the CQC found on their inspection was some poor multidisciplinary team working, so that working between particularly the consultants and some of the senior midwives. Some of the training wasn't always up to date. We have had some shortages, staff shortages in terms of midwives. However, I am pleased to report we have recruited 20 midwives, and we will be up to establishment. There was also some vacancies within the consultant and middle grade workforce. There were some issues, and some of the issues were identified from the serious incidents I referred to at the beginning around escalation. So junior staff feeling able to escalate their concerns either up the midwifery channel and or to the consultants. And that the maternity unit is split into a number of different areas. So we have the delivery suite, we have the antenatal area, and we have the postnatal area. And we also have an area which is predominantly for low risk women. And what we'd seen over a period of time was we'd had a number of the high risk women, because as I said to you earlier on, the number of high risk women had increased. They were being cared for in a low risk area. Now, there was lots of mitigation put in place, but the CQC didn't feel, and of course we agree, that isn't always the right thing to do. So we were seeing high risk women being cared for in a low risk environment. So they came back and they did a follow-up visit. Some of the issues they found on that visit, as I said, they did see lots of improvement, but there were some own goals, unfortunately. They observed some staff fiddling with their masks, so in the clinical environment, not always maintaining social distancing, and some say staff fiddling with their masks. The handover period between, so at the beginning of each shift, the consultants and midwives and junior doctors have a handover period. That wasn't consistent on their visits, and not all staff attended at all the right times. They also found some areas where prescription charts weren't completed accurately, and they spoke to some junior doctors who were tired and felt not always completely supported. That was disappointing for us, because the week before we'd had HEE in, who'd done a visit and actually had found the complete opposite. Who'd found that the staff felt very supported, the junior staff felt very supported, and there were no issues or concerns raised from the junior doctors at that time. We'd introduced a lot of new training, particularly around the monitoring of women and the monitoring of babies. And they found, it was reported to them by one midwife, that all the doctors hadn't done the training. That wasn't true, and all doctors do the training. And there were some issues around some new guidelines that had been implemented, didn't match the national guidance. So they were the issues that have been raised over the last few months. So I want to just go on to talk to you about the improvements that have been made. And James and I James come and met with Claire and I, was it last week, James? And we talked James through these, but just to talk you through them also. So we have, I'm sure you're sitting there thinking, what about the leadership of the maternity department? So we have got a new leadership team in place. We've got a new clinical director, Mandeep Singh. He's a consultant from Southend. So he now is the clinical director at Basildon, covering all 3 sites. We've also got an interim director of midwifery. I recognised some time ago that we've got 3 sites, 3 heads of midwifery, but actually really to strengthen that midwifery structure, we need a director of midwifery. We have been out to advert 4 times and have been unsuccessful in appointing. If anybody knows where I can get a director of midwifery from, let me know, but it's been a real challenge to get that person in post. But I am pleased to say I've got an interim person who actually is an ex-head of midwifery from Bedford, very experienced, and started last Monday. There are lots of new systems and processes in place, and if I was being very candid with you, I think that's some of our challenges at the moment, that we are trying to do an awful lot and implement lots of new changes. And actually staff are finding that a challenge, as well as obviously caring for the women and babies as normal. We invested £1.8 million into new staff. I said we got 20 new midwives starting. We've had 29 start up until this month, and that includes some maternity support workers and also 2 consultants, and they are now in post as well. We've actually created more delivery beds for our high-risk women. I told you that the number of high-risk women has increased, so we've increased the number of beds by 3. We've created a new triage, 24-hour triage service. Again, where we've seen that shift in women in terms of the higher risk, and that complexity of those women. So we've created a triage service so that women can be seen immediately when they come, and they can be triaged into the appropriate place for their care. We've now got a midwife lead for better births. She's been recruited. Continuity of care is a very major thing in terms of caring for our women, and we've now got 2 teams in place already to ensure that continuity of care for our women, and that's quite a significant change for our staff, but a significant improvement for our women in terms of we know that that's what our women want. Our bereavement room has been restructured and is having refurbishment done on it. We're in the process of having a new birthing pool built. That is causing some difficulty just in terms of the environment of the building, but that work is in progress. We've had building works done to our drug rooms to ensure better medicines management safety. And we've had work done on our entrance and security, particularly around controlling any potential abduction of babies and exit of people and entry of people. So that's been tightened. And we've also done some work around our staffing and escalation policy. So there's an awful lot that has been done. There's an awful lot to do, particularly around some internal governance arrangements and making sure that we've really got those robust reporting, escalation and monitoring arrangements within the unit. And in particular, obviously having a new leadership team, that does create the opportunity to do so. We've also brought a matron from Southend to the Basildon site in a deputy head of midwifery role to really strengthen that leadership team. And we've also now brought in an improvement director 3 days a week that is focused purely on maternity to really pull together and give them that support to lead the change forward. So in terms of, I think it's important just to share with you those next steps as well, because there's a sustainability of the things that we have already done, but also it's important to continue working. And as I say, there's still lots to do. So we have, as a direct result of the CQC findings, we have been put on to the NHSI Maternity Safety Support Programme. And in fact, I'm going straight to that meeting next. So I think that will be a great support to us. We have had an awful lot of support from NHSI and our CCG colleagues already, but I think that will be really helpful moving forward. We've also engaged on the GMC and the NMC development programme from our staff, because we do believe, and it has been identified, that there are a lot of cultural issues between consultants, doctors and the midwives. And of course, unless we get the cultures, values and behaviours right, it's very difficult to move on anything else. We have just launched a new governance model across the group for maternity, which, as I said before, that we need to have consistency and standardisation of our processes, and that hasn't always been the case. We've also just appointed a new.
Sorry, Diane.
Yes, sorry.
So I'm aware you said you need to go at 10:30. If
Sure.
You can wrap up in the next 2
minutes.
Yeah,
I'm almost there. Almost there, James. We've also appointed a new governance lead that started on Monday to really lead the governance and the risk management side of things. And then we've got a very in-depth improvement plan that we report to the CQC on a weekly basis, as well as the CCGs and NHSI as well, in terms of that continual monitoring of. So I'll stop there. That's the end of what I thought would be helpful to say, and obviously happy to take questions.
Thank you very much, Diane. And obviously, I very much welcome you attending our Health and Wellbeing Board this morning. Questions for the Chief Nurse? Sheila Murphy.
Hello, thank you. That was a really thorough feedback about what you're doing, and it sounds like there's a lot going on and it should be positive going forward. I think what I didn't hear, though, was about how we capture the views of women and mothers and people who use the actual maternity unit. And I don't know if you've had, since that report was published, if you've had women sort of saying they don't want to have their babies delivered, because it's obviously a very vulnerable time for women. And if you read a report like that, you sort of think, oh, I don't know that I want to be put in that position. So I was just wondering, how do you capture, because it's really rich information, if you get information from mothers about their experience, because mothers will be the ones who will know that there's a disconnect between the doctors and the midwives, or actually they've been in a position where they haven't felt safe, and or that they think things are improved, or that they've had a good service. So that's what I was just sort of thinking, how do you build that in?
No, two things. Firstly, your first point in terms of women not wanting to come here. We did do lots of communication work, particularly when the report was published. We saw 19 women that wanted their care transferred to Southend Hospital at that time. It didn't impact on Southend in terms of their numbers, so those women were cared for and their care was managed effectively. In terms of numbers, that wasn't an issue. What we have done since the report is we do a daily a sample of 10 women each day to say, what did we do well, what didn't we do well, and we report that to the CQC on a weekly basis. I'm relieved to say there's been nothing awful. Most of the comments, the negative comments, have been around I had to wait for care. We've had some around it took some time to get some pain relief, but there've been, and that of course is a worry, but there's been nothing. Most of the comments have all been very positive and complimentary to the staff.
Sheila, are you happy with that? Would you like to respond?
No, that's sorry.
Oh, Sheila.
Sorry, Jen. No, that's reassuring. I just think it's really important that we, when we're talking about doing recovery plans, etc., that if you are doing stuff with women that use it, then I think it needs to be sort of higher up the list of that's what we're doing. So it sounds good. Thank you.
I'd be more than happy to share. We will be writing up the feedback as well, so we'll be more than happy to share any feedback that we do, positive and not so good as well.
Okay, I've got Teresa Kearney, but she's not appearing on my screen. So if you are there, do you want to make yourself heard?
Hello, yes.
Oh, hello.
Hi, yes, Teresa Kearney. I'm from BBCCG. Work very closely with Diane with respect to maternity. Just to supplement that information and for Sheila's assurance, we also are working very closely with the Maternity Voices Partnership. And the Maternity Voices Partnership are women that use the services across Mid and South Essex. And we work very closely with them, and they offer us regular feedback when they do surveys. And that's site specific, so we know where the comments are coming from. And we also, when there's anything that's negative, we also make contact with the head of midwifery, and they always investigate and feed back to the lady. So there's a personal touch to it, but there's also a system feel with respect to how this is progressed and how we interact with Maternity Voices Partnership. In addition to that, they're also doing doing some co-production work where we're working alongside the Maternity Voices Partnership to produce material for women, for women's use, especially with respect to inequalities agenda and the BAME groups across our areas. I hope that supplements a little and gives a little bit more of a comprehensive view.
Tanya?
Yeah, I was just interested really, Diane, thank you. It was really, really helpful report. About whether more women are having home births. Obviously the COVID experience is different anyway, but I just wondered whether, because of the concerns of this report and COVID, whether we're seeing a real shift to home births at all?
No. No,
okay,
not at
thanks.
all. The numbers really haven't shifted. We have seen an increase in our section rates, but not home birth rates.
Okay,
and that's partly because of the high risk women and partly a little bit because of COVID and women's choice.
Okay, thank you.
Okay.
Diane, if I can ask, obviously you referenced some previous reports about maternity services. There have obviously been issues rumbling on for quite some time, and I did mention this to you when I met you, that Southend are not in the same position with their maternity services. So within this merged trust, what can we expect to see? Because we have seen that Basildon have had long-running issues with maternity. It's a concern that these issues have now rumbled on for a number of years, and it seems to be the only part of the trust that is really struggling with maternity. So why has the issue rumbled on for so long, and what pressure can the wider trust bring to bear to make sure that Basildon is not seen as a poor relation?
Yeah, good question, and I know we've spoken about it before. So I think, why? I think part of that, as I've alluded to already, is around that risk, that high risk women coming here, and we've struggled to keep up with the high risk women. In terms of what we can see as a merged trust, what we are doing is doing lots of compliance visits, if you like, in terms of across the other two sites. And I think it's important to note that they aren't about marking our own homework. So we've had the CCG and NHSI being part of those teams, really testing all of the things that have been found at Basildon. Are they there on the South End and the Broomfield sites? And in fact, Teresa was on one of those. They weren't there. The issues that we have at Basildon around particularly the culture aren't evident on the other two sites. So there's something for us around where we've got all the good practice, we're sharing it across each site now. And equally, where we pick up poor issues and poor compliance, then we will share those and double check those on the other sites. So there's something very much around learning lessons from the other sites, and equally where we've had the rising stars, because it's important that we have that career pathway for midwives, that we share and support those individuals. As I said, bringing the person from Southend, the matron from Southend to Basildon, to share her skills and knowledge from the Southend site, but equally making sure that we don't leave one site light by moving staff around too much. So it's that balance, of course, around the three sites, but making sure that we share good practice.
Thanks, Diane. I fully respect what you're saying about a higher prevalence of high-risk women in Basildon, and that puts a certain pressure on those local services. But I have to say that reading the report, there are several references to a poor culture within the service. There are several references to professionals, frankly, not getting on with each other and not being attuned to either the thoughts of their own colleagues or the thoughts of the women that are meant to be serving. So I certainly hope that it's not just going to be attributed to a difficult cohort of patients and what are probably systemic problems in the feeling of the team, that those problems are really robustly tackled.
Yeah, no, absolutely. And firstly, this isn't around a difficult cohort of patients. This is around a different cohort of patients and a high risk cohort of patients a higher risk cohort of patients that we see to Southend and Chelmsford. But the piece of work that's being done here that isn't being done on the other two sites to as much degree is some organisational development work with individuals, both as individuals around behaviours and values, but also in terms of the teams as well, because it's not just around one individual. This is around team working, whether it's a team of consultants, a team of midwives, and or them equally working together. So there's a comprehensive plan around organisational development, but equally professionally some of these behaviours aren't acceptable, and that's also why we've engaged with the NMC and the GMC to put that added professional slant onto it, because these are professionals and they need to be held to account.
Thank you, Diane. Tanya, your hand is still up. Anyone else? Scrolling through my roll.
Tricia Dorsey's got her hand up.
Oh, beg your pardon, Tricia.
Don't worry. Thank you, Councillor and Chair. Can I just talk about the confidence that the appointment of Mandeep Singh to that clinical director role and to support Basildon? I'm the chief nurse for Castle Point and Rochford and Southend, and historically we had some issues. And Mandeep went into that unit and did some fantastic work, which has brought about sustainable change with regards to the culture within the department, which is why we're in a good place now. I think the influence he can have on the teams at Basildon is going to be significant, and I think that will put the trust in a very good position. So I really welcome that appointment, because I've seen firsthand the influence, not of one person, but of the one person effect on the team dynamics. So that's why Southend's in a different place now.
That's really terrific to hear, and thank you. Just before you go, Diane, the final question I wanted to ask was, in regards to vulnerable women giving birth in the hospital, and the type of women where you might need interaction with Thurrock Council, Children's Services, Social Services, and same with Southend and Essex County Council, can you just speak a little bit about, given all the high-profile problems with the team and morale of the team because of this inspection, can you just talk about how you're going to make sure you continue to work with social services and we don't see perhaps premature, hasty discharges where perhaps social services should be more involved, hand in glove with you, before those mothers leave your care?
Yeah, no, of course. So we've also, as part of that coming together as a merged organisation, have got a new safeguarding team in place, and we've got designated maternity safeguarding leads, and part of their role is to absolutely do that liaison and again sharing and learning good practice. And what I'm encouraging them to do is to set up regular time slots with people so that we build and ensure that we have those good relationships with external stakeholders. So it'll be helpful to have regular feedback on that, James, moving forward.
But I'm sure we can facilitate that happily.
That would be really helpful, yeah.
Yeah, and certainly have you back for perhaps January board. Are there any final questions for the Chief Nurse? No? Okay, Diane, thank you very much for your attendance. We really appreciate it. We look forward to seeing you again soon. If there's anything we can do to help in terms of the improvement journey, please let us know.
Thank you. That's greatly appreciated. Thank you. Bye-bye. Bye-bye.
Okay, so we've now got an update report on the SEND Improvement Board. I don't think Michelle's on the call. Sheila, are you presenting this?
Yeah. Okay. I'm going to assume everyone's had a chance to look at the report, so I won't go through it word by word. But just to say that this report is setting out basically the work that we've been doing in relation to the written statement of action around our SEND services. People may recall that we had Ofsted come in March 2019, and we were given, there was quite a bit of positives in the report, but there were some areas that needed some serious development and improvement, and we were given three what are called written statement of actions. In the report, we've highlighted those three written statement of actions, and what Ofsted will do in sort of 18 months to 2 years time since the report, so probably between next April and September, we'll come back to the service and we'll review those three written statement of actions to ensure that our practice across the service and across the system has improved sufficiently so that they don't feel that we need to have those written statement of actions anymore. So there's a very comprehensive response to the written statement of actions, including a multi-agency operational group as well as an improvement board, which is chaired by our portfolio holder for education. And all of those groups that are set up go through all the actions that we have against those written statement of actions. And we have a very comprehensive action plan against it. So we have been working very hard as a service and a system over the last 18 months to make the improvements that are required. We have had some delays due to COVID, and I think most people are aware the statutory guidelines have been suspended or extended during COVID time, and they've just now stopped, which has meant, and that's partly because in order to have effective education healthcare plans, they are a multi sort of agency response, and quite a lot of our health colleagues and our school colleagues during COVID were not able to concentrate on just the education input, and actually that was recognised. So where we've had to extend timescales, that's been fully reported to all the respective boards and updated in our plans. What we've listed on the report that's at page 48 and page 49 of your pack is a number of areas where we've made progress. And so some of those have included, one of the written statement of actions was about being clear where all the children are in the system. And the problems we had when Ofsted came is we didn't have an effective IT system that could just simply, at touch of a button, produce a report that told us where those children, which schools they were in then. We have had an update on that system, and now we have effective information that allows our managers to manage effectively and to ensure that children's needs are being met appropriately. So that's been an improvement. Another big improvement has been in the timeliness of education healthcare plans. When Ofsted came, I think we were in the 40–50% being completed within statutory timescales. We're now hitting 75–80% on a regular basis, which is above national returns on this indicator is around about 65%. So that's been a really big improvement. And what that brings is children's needs have been identified earlier and appropriately, and they have their needs met quicker than they did when Ofsted came last year. So there are, and we've had resources put into the service. So we've got extra SEND caseworkers so that they can make sure that they are being responsive to children. And caseloads have now come down for a caseworker to around about 150 cases each, which is, I mean, significantly lower than we had at the time of inspection, and also more in line with other services, SEND services. So there's been a great deal of work that's gone into improving the service and making sure that we are on course. There are still areas where we need to improve. So we've done a lot of work on quality assurance and actually making sure that we are looking at, so we've got timeliness, but have we also got quality? So we're doing work now making sure that we have the quality of the plans. We're doing a lot of work on participation and engagement. I think most members will be aware that we had a family, a parent organisation, which has now ceased to function. However, that's fairly usual in SEND work, where you have a cycle of families being very engaged. As their children grow older, they then move on, and we need to then re-energise those groups. So at the moment, we're in the process of re-energising our participation. There's a section here on stretch targets. That was part of what we put through on our action plan. Is being able to reduce the number of weeks for an EHCP to producing them at 16 weeks. And we targeted that for around 2021. We will need to be reviewing that timescale in light of COVID. But I think what we need to know as a board is that we are meeting the statutory required timescales, which is 24 weeks at a very high rate. We also had a stretch target about responding to calls within 48 hours. And because we have had investment in both staff and telephone systems, we have been meeting that target. And it has actually led to a decrease in the number of complaints to the service. Completing the annual review paper is linked to the online portal. So the stretch target will be reviewed as we develop and project and the implementation plan for the HCP portal. So I think that's a bit of a quick whiz through that comprehensive report, but I'm hoping you've read that, and I'm happy to take any questions.
Thank you very much, Sheila. Look, going through some of the metrics, a lot of this is very, very good news. Very pleased to see that we are responding to far more calls within 48 hours from parents. This is excellent. Timescales are coming down. I'm very concerned that two of the stretch targets that have gone missing are in regards to the actual outcomes. of the plans themselves. So a lot of commentary beforehand was making sure that the plan itself wasn't just actioned in terms of all the elements were followed through by the school, by the local authority. The focus was making sure the plan that was written in such a way that it enabled that young person to meet their own potential, i.e. it wasn't just a good plan, it was the correct plan for that child. A lot of that commentary seems to have gone missing. Could you speak to that a little bit, please?
Yeah, I mean, this is obviously an overview report, and I think I've touched on the quality assurance work that we're doing, because you're quite right. You know, we are getting now, we've reduced caseloads, which you then would expect to mean that we are producing the reports and the plans in a more timely way, which is what we're seeing. But the next stage of our improvement is not only are we producing reports and plans in a timely way, but actually those plans are well written, you know, addressed, that are not cut and paste, because that's one of the things Ofsted picked up, was that some of the plans were cut and paste, which meant they didn't necessarily always reflect the current needs of children, young people. So what we're doing now is, with our QA work, is actually looking at randomly across agencies. So we have a multi-agency group that looks at those EHCPs. And what we're looking for is exactly what you're saying, James, is, you know, the so what question. So are these plans actually addressing needs of children? Is it clear? Can you and I understand what's in the plan? And is it something that we can measure, that actually we know that those children's needs are being met? I mean, maybe you might want for the board going forward some of our QA work, so that we could report back in terms of quality rather than just numbers, and would be happy to do that.
Yeah, I think that would be good, but obviously the QA needs to focus on not just quality assurance in terms of the plan being of high quality and being actioned correctly. It needs to speak about the plan actually being sufficiently ambitious for that child. So if they're a D grade student at the point the plan is written, and they have the potential for a C or a B, or sorry, a 5 or a 6 in new results, then we need to make sure that that is what the plan is designed to do. So it's not just a quality plan, it's the correct plan for that child. And can you speak a little bit about the time frames? Because in terms of COVID potentially throwing a few things out, my understanding is that in terms of forming and signing off the plan, about 95% of it is a desktop-based exercise anyway. So I'm not quite clear why COVID would cause particularly significant delays.
It's not a desktop-based exercise. We need, for some children, young people, certainly in their education healthcare plans, we need people with expert opinions. So it may be occupational therapy, it may be health services in different guises have to write reports and do assessments, as well as educational psychologist assessments, school assessments. Part of the issue during COVID, certainly for schools, was that schools were only, well, schools stayed open, but the pupils that went to school were those pupils who were considered to be vulnerable and key worker children. So if you are a child who had emerging SEND needs and was in the process of having assessments, they were not necessarily physically in school, so we weren't getting the same assessments that we would need to have to inform their plans. And the same with some of our health colleagues who were directed to work elsewhere in the health economy during that COVID period, were not available to be involved in that multi-agency assessment that does lead to making sure that the child's needs are being met correctly. So this is a national issue. It wasn't just in Thurrock, which is why the government relaxed some of the legislation, and in terms of SEND created the phrase reasonable endeavours. So took away the requirement to have certain things within certain timescales, and said during COVID that we had to evidence that we had undertaken reasonable endeavours to make sure that children's needs and that multi-agency assessments were taking place. So I would say in Thurrock we've done, you know, we work really well as agencies on these issues, and we have made sure that we have been getting information through, but we've not been able to do everything within the timescale, certainly through COVID. And when I say through COVID, that's probably from April through to August. You know, things have improved in September. Schools are fully back now, so it's not just a few children that are in the schools. The schools have got all the children back, and I know a lot of our children's health colleagues that were moved elsewhere have returned and are now back into business as usual. And the legislation that had been relaxed, that ceased on the 25th of September. So we're back now to being within the legislation as required.
Any further comments? Can't see anyone. Okay, thank you very much, Sheila. Economically Vulnerability Task Force. Roger, do you want to introduce?
Make sure I'm off mute. Thank you very much, Chair. So what we've presented today is very much a progress report on what we call the Economically Vulnerable Task Force. This was an initiative that the Chair of the Health and Wellbeing Board set up a few months ago. I think we've had 4 meetings now. It said 3 in the report. I think we've had 4 meetings now. Essentially, what this group is aiming to do is bring together a coordinated approach across the council and with partners to try and ensure that as a result of the economic downturn, which obviously was going to be quite severe and prolonged, people who may well be categorised as economically vulnerable don't suffer even further. We haven't got an absolute definition of what is economically vulnerable, but that certainly includes people who have traditionally found it hard to access full-time employment, and that will be care leavers, people with mental health needs, people with learning disabilities. So we haven't got an absolute definition of economically vulnerable, but it's pretty much those group of people who have traditionally found it hard to access mainstream full-time employment. So what you've got in the report is the progress report in terms of what we've done up to date. What is also very important is that you've also got attached a report that was approved at the Thurrock Council Cabinet in September, which is our strategy around economic recovery. So we very much want this to be not only something that's done as part of the work within adults and children's services, but as part of the mainstream work that we're doing in working with businesses and the local community around supporting and hopefully leading towards a stronger economic recovery. So just go through some of the initiatives. We have obviously getting the data has been our first task, because it's not necessarily data that we hold comprehensively at the council. So we wanted to understand what the position was around the claimant count, and particularly people who, as I say, that vulnerable group. We're working very closely with the DWP, so they are part of the task force. We've arranged, certainly in adults, of separate meetings with key people within the DWP to make sure that their programmes, because they do have quite an extensive programme of support, we coordinate our activity. So I think there's some very positive working with the DWP. In adults also, we have a programme of work funded through a voluntary organisation. So the Thurrock Centre for Independent Living has a programme called World of Work. And as part of the government's COVID funding support, we're able to give them some extra funding between now and March next year to give them some extra support. Now, they very much work with people with learning disabilities and people with mental health challenges, particularly helping people in that preparatory work around CV writing, interview preparation, job coaching, and clearly, as you would expect, their numbers of referrals have grown. So we've given them some extra financial support to make sure that they work very closely with that group. I think this group is going to continue for some time. I think we recognise that it's going to be quite a difficult period with the economic situation, but I think it's a very welcome initiative. We're meeting monthly as a group, and we want to make sure that where possible that we involve all partners into this process. So I don't know whether Sheila would like to say anything specific around children's and care leavers, because I know obviously that's something more in her area. But just to conclude, we're working very hard to make sure that people who maybe find it difficult to access work don't suffer double discrimination, and I really welcome the work of this task force.
So in terms of children, vulnerable young people in that older cohort, we have a very good service in Inspire who are doing a lot of work with post-16 and working across the transitions around employment. And we've linked up with services across Southend, Essex and Thurrock to have a wider reach in terms of offering, whether it be apprenticeships. There's a new scheme around that's called Kickstart from the government, which provides for 6-month placements for that older young person range, where they will fund the 6-month placement, so employers don't have to do that. So we're looking at the moment about how we can get that in place. We have advisors available that talk to young people about what's open to them and what the possibilities are. So you're quite right, there's a lot of work going on in this area, and you know, our concern is going forward in the next few months that there will be more young people finding themselves in difficulty in terms of either not being able to get a job, not being able to hold one, and then finding one. So there's a lot of work going on in that in children's services.
Mark Tebbs.
Thank you, Chair. Just to say, obviously, we're concerned about this from a kind of from a mental health perspective and kind of a well-being perspective, and just for some assurance, we as kind of health partners are also investing in employment support for people with serious mental health problems through a kind of program called Individual Placement and Support kind of methodology. So I think it's a shared partnership concern, and we're using the mental health partnership board to kind of make sure that the kind of offers are very much kind of tied up, but yeah, looking at it very strongly from a kind of mental health perspective as well.
Any further comments, anybody? Yeah, I think it's very important that as we go forward, we recognise that we do need to have a very significant NHS input, not just in terms of thinking power, but also, frankly, financially, because employment is one of the key determinants of good health and well-being. I think we need to accept the position is still evolving. Economic breakdown is going to continue for some time, which causes housing breakdown and family breakdown and drives people towards care. So I think we need to constantly challenge ourselves on what the profile of vulnerability looks like, because I think vulnerability is going to continue to change very, very substantially. We've not had particular conversations about mental health so far because we've been focusing more on direct economic support, but we do have a meeting on the 5th of November. I don't know if Mark or someone from the CCG will be available to attend and speak to us, because I certainly know we also have the pupil referral unit returning that meeting to talk about some issues that they see with their cohort. Councillor Fish? You're on mute, Councillor Fish.
Yeah, so it's an area that I'm very interested in. I was involved in setting up the World of Work system when I was involved with, as it was known, Turk in those days rather than TESOL. So I'm aware that employers can often have an unconscious bias when it comes to employing people with learning difficulties or people with mental health issues. So what can we do to address those kind of unconscious biases that people have? They're kind of discriminating against people unfairly and unnecessarily.
I think I'll let Roger try and respond. But what I'd say, Councillor Fish, is if you look at the economic development strategy that we're going out to consultation on, the entire document is littered with references to the learning disabled, references to care leavers. So what my group is trying to do is trying to put the economically vulnerable at the heart of every single conversation. That's why we've had the PRU in to talk to us. That's why we've had Department for Work and Pensions talk to our group. That's why we're going to soon have the CCG, and we've already had other health and housing partners in to constantly insert into the conversation the issues that the disabled face, that those with mental ill health face, to ensure that every conversation about economic development is not just generic and broad based, it is more specific and targeted. Roger, have you got something you'd like to add?
I think Councillor Fish makes a very good point about unconscious bias, and that's a very difficult one to challenge, because by its very nature it's unconscious, and you need to bring it out in the open, and you have to have a whole different mindset. I think what we do need to do more is work more closely with local businesses. Our intention is that we will take something to the local business board. In this, already the economic development strategy has, in its first draft, been to the business board, and once it's now it's been through cabinet, we will take it back to the business board. As I say, we also work, just to reassure you, that a lot of work through the DWP is also working directly with businesses, so around placements, around training opportunities, around supporting people. Not everyone wants to declare that they have a mental health issue either, so there's something around providing people support prior to them actually approaching an employer. So I think it would be, Councillor, just to reassure you, it's very much on our agenda. It's not going to be an easy one to solve, but it's very much part of the work of this particular task force.
Yeah, okay, thank you. That's reassuring to hear. Thank you.
It's a good point, well made, Councillor Fish. I'm pretty sure I saw Nigel a second ago.
Yes, thank you, Chair. Thank you very much. Just to let you know that we are due to come to HOSC next month to update on mental health. So we have a team of employment specialists that operate within Essex. Within ePut's range of services, we have Enable East. They've got a big lottery grant specifically targeted towards maintaining people with mental health conditions in employment. So if you're happy to, we will add that into our report that's coming to HOSC next month.
That would be excellent, thank you. Roger, can we make sure when we're setting up the December meeting of our task force, we invite Nigel and Mark, so we can give some specific focus to the mental health employment agenda, please.
Sure. Was that the November or the December meeting, James?
The December meetings. I think the November meeting is already pretty packed, and I don't want to rush this item because it's very important. Mark, is your hand up again?
Yeah, I think we could also bring in the work that's happening around kind of the anchor institutions work. So I think there's a big focus within the kind of inequalities work around the kind of role of public sector, NHS as employers and procurers of services. So so I'm happy to kind of bring some of that into those discussions too.
Thank you very much. Any final comments? Excellent, everyone. Thank you very much. Then finally, we have the Greater Essex Leader Annual Report. Rebecca, are you? Oh,
yes, here I am. Yes, sitting here quietly. Thank you, Chair. Yes, so there are a lot of reports and documents attached to this, which I'm hoping you've had a chance to at least glance at. In the report cover sheet, I've summarised some of the main issues. So this is a report running up until the end of March 2020, so with the data from the previous 12 months. So obviously we've already, turned over a lot more reviews and learned a lot more, but this is the position at that point. And it covers all of Southend, Essex and Thurrock, but some of the breakdown can be seen in the supporting data. So at that point, there were 10 cases that had been completed and reviewed for Thurrock, 4 of which had died of cancer. So that's maybe more of an issue for you than for the overall picture. But I think that if we look at the bigger numbers, we can see the themes more clearly. And I think as we go through the programme, those will become more and more relevant for each smaller area. So overall, we found that people were dying of pneumonia. That was the highest direct cause. So if you looked at 1A on the coroner's report or on the cause of death certificate, pneumonia was very high, followed by aspiration pneumonia. Now, sometimes that was a pattern of frailty and deterioration, which we're seeing early. Sometimes the aspiration pneumonia was a mismanaged feeding issue where maybe guidance wasn't fully understood of the severity, but the importance of it. Cancers are also up there. Sepsis has kind of reduced somewhat from our last year's report, but we believe that's because when you hit that pattern of deterioration where the immune system is not functioning well, you're going to go from something either a sepsis or a pneumonia or both. And actually it's a matter of what goes on the death certificate as the prime cause, rather than the fact that sepsis has disappeared. But we have done a lot of work on awareness of it, so we're hoping that people are catching that also. So in terms of the detail there, I don't know if there's anything. There's a lot of information in it. I would recommend that you read the themes document, because that really pulls out of the 318 recommendations the key areas. So what I've tried to do there is say, given what we've learnt and the detail in the recommendations about what needs to change to stop these early deaths happening. So we're still seeing around 60 in Thurrock, maybe nearer 65, which is great, but it's still much earlier than the rest of the population. So what do we need to do to change this, to stop the health inequalities, to really promote great health, involved planning and understanding of health with people with LD? The themes document takes those recommendations and puts them into areas that is across multi-systems. We all need to act on stuff, and then by organisation. So social care was highly indicated, primary care, acute hospitals, specialist health, and so on. And then some condition-specific recommendations like heart, long-term conditions, COPD, and so on. So that themes document pulls out the main themes in a way that we can action them, and it also recommends actions that need to be taken. So that's really the information for organisations to pick up and run with. But we have identified 4 main themes, which as an overall system we've agreed will prioritise to the end of March, and those are annual health checks, which you can imagine is challenging currently, frailty because it's the leading cause of death, and ill health, a dynamic support register to monitor and escalate physical health issues, and case management, where we work together to really have an overview and a joined, shared understanding of a person's health and well-being. So we've commissioned, as the leader LAC, I'm also an integrated LD health commissioner. So we've commissioned our specialist health provider ELDP to work predominantly on those 4 areas over the next 6 months, and the CCGs and local authorities have outlined where that fits with their work streams and what's going to happen. So really for this board, it's information to note the reports and the action plan, and to confirm if you're in agreement.
Well, thank you very much for your presentation, Rebecca. I wonder if I could just drill down on one issue a little bit more. In terms of the learning disabled, we know that because of COVID, there are substantial backlogs in parts of the NHS, especially in cancer diagnosis and treatment. What can be done to help explain to the learning disabled community the cause of some of these backlogs? Because I know an awful lot of work is done in social care to support people in their independence, and a part of that work to support the independence of the learning disabled is making sure they know how to flag issues. Obviously, the system is not behaving the way the system is meant to behave now. So is there anything that local authorities should be looking at in terms of making sure that while the system does face all these log jams and backlogs because of the lockdown, that the learning disabled aren't overly burdened by this.
I think that's a really good point, and I think it's something we've probably not picked up. I can't think of any easy read or comms plan that actually tackles that specifically. I think things that maybe relating to that are that people are often seen as having capacity if they're managing quite well and can say, no, I don't want this. There's lots of work that was highlighted around health insight, and I think that's possibly linked with this, that people tend to say, well, I don't want it, or I haven't got it, but they don't advocate for themselves. So there's an issue about advocacy there and how we involve that better, but also how we explain the implications of health and health decisions and options to people. So there's an easy read toolkit which was developed by our specialist provider in the north of the county that I've tried to circulate widely, that helps people have those conversations. And I think it's probably more of that, but you're right, maybe there is something additional and specific about the changes to healthcare provision, certainly that people are not getting their annual health checks, which is often the first point that something is picked up, but also that if they've got things planned, they're maybe not happening either. Yeah, I'll take that one back.
Thank you very much. Roger Harris.
Thank you, Chair. I've obviously had sight of this report before because I chair the Learning Disability Health Equality Board for Essex, Southend and Thurrock. In old money is what the Transforming Care Partnership would be. You've also got the Vice Chair, you've got Tricia on the call as well, who I'm sure will want to come in. I think the whole leader process I think has been very positive. It has shone a light on some of the areas where we need to up our game. I don't think this Health and Wellbeing Board has had a discussion for some time about a number of the areas that have been highlighted in here. Previously, a couple of years ago, we were very monitoring very carefully where we were with health action plans, and I know there were improvements, but that improvement now seems to have stalled for whatever reason. We obviously have had a lot of issues, a lot of conversations, put it this way, about our specialist LD arrangements and how they link into local service provision. It continues to be an area I think perhaps it went a little bit under the radar during COVID as well, so we might need to make sure that we. So what I'd like to recommend, Chair, is that we, maybe not for the next meeting, but for the future, for the meeting after that, have a more comprehensive overview about where we are with some of our strategic thinking around learning disabilities, particularly with things like health action plans, because we really need to get on top of those. Again, it has been a long standing bone of contention as to why we cannot get nearer 100% for those. It still continues to mystify me why we are still performing so badly on those, but then also not only doing them, but the quality of them and the outcomes that come out of those. So I think this is a very welcome report because it shines a light on some areas that we need to focus on. But I'd like to suggest, Chair, that we have, from a commissioning and service point of view, a more specific report coming back for Thurrock, maybe in 2 meetings' time, about where we are on some of those key priorities that Rebecca's highlighted in section 3.
I think that's a very good idea. Patricia?
Thank you. I just smiled, Chair. Patricia is my very formal name when I've been naughty. There's 3 things I'd like to say if you would give me the time. First off, I think thank to Rebecca and Phil Brown and the team for this significant grip that they now have on Leader. We were flapping in the wind a little bit, but we've now got excellent processes. We've got themes emanating from the reports, which are informing the way that we commission for the future. With regards to the reduction in sepsis, this has largely been due to a training programme that we instigated for carers to make them aware of the early signs of sepsis. And as a result of that activity, we've seen a significant reduction in sepsis, which is, that's huge. Sepsis is a condition that we all fear. As part of the reset programme, I think the question you raised about reasonable adjustments and communication to those that are on the waiting list, I'm happy to take as an action through our patient quality meetings, which are focusing on the backlog position, to ensure that we are considering how we communicate more effectively, that those individuals with learning disabilities, Rebecca. So rather than you needing to action, I'm more than happy to take that forward.
Great, thanks.
And then finally, with regards to the LD health checks, we've stuttered along over many years with regards to performance. It's something that the CCGs communicate with their primary care practices regularly on the importance of the check and the need for those checks to be of a high quality. Following on from Simon Stevens' phase 3 letter, where LD health checks have been prioritised as being something that we need to improve towards a 75% trajectory, Mid and South Essex Healthcare Partnership have a quality improvement leadership programme, and there is a focus on learning disability health checks. So I am the SRO for a group that I met yesterday who are going to use quality improvement methodologies to see what we need to do differently to improve the uptake and the quality of learning disability health checks. Now, I'm more than happy if the reports come back here to provide information around the outcomes of the decision making within that group, and to give you an update on our, how we're moving forward on the trajectory. So there is a huge amount of work going on in the background.
That's very, very good to hear, and I think we would very much welcome that update. And I think if we were going to invite Rebecca back, I think I would like as Roger said, in maybe 2 meetings' time, a slightly fuller conversation. I'm very conscious of the fact that I have elderly and infirm constituents who've contacted me about delays in hospital care. So it does concern me greatly to think of the position the learning disabled would be in if they were expecting, or they become accustomed to a certain service and the system is not responding the way it should. That does worry me a great deal, and I think that it's something we need to consider very carefully, because where the system is now going into lockdown, my very clear opinion is that lockdown is a part of the business of health and social care. It happened. Winter pressure is a part of the regular business of health and social care. It happens every year regardless. So there is no reason that the learning disabled aren't given the care and attention that they require just because we're going into the winter months and the system will see challenges. The system always sees these challenges, and we quite simply have to navigate that for these people. Rebecca, did you want to come back?
Yeah, just to add something to that, during the COVID period, the first wave, I was collating the LD inpatient lists. The liaison nurses were sharing them with me, and I was then sharing them with the relevant social care and specialist health bodies. And what was interesting was that we were saying, what's happening to those frequent flyers who seem to have maybe poorly managed health conditions in the community and are now not coming into hospital at all because of fear of COVID. Now, some of them, we anecdotally heard that GPs were actually supporting them better in the community because they knew they couldn't go into hospital. So that was an interesting, given the dares and issues that have come on since, that was interesting. But also we've since seen a relatively high level of death coming in, so high level of notifications to leader since people have been able, the lockdown has reduced. So what we need to do is provide, one, the COVID report on the 22 COVID deaths we had of people with LD, but then also look and review the why people are being admitted across different periods and see if it is those unmanaged health conditions because people couldn't go in. And I think that we need to do that urgently, but it's resource to get through the reviews, but we will get there, and we will perhaps come back and present those reports to you.
Thank you very much. Are there any further comments on this item? Get my hands. No. Well, thank you very much, Rebecca. I think that we're now coming on to the work plan anyway. So if I ask Darren to take us through the work plan and possibly suggest a correct slot for us to return to this conversation at a later date. Darren?
Hi, Councillor Alden. Yeah, the work plan. So we've got a meeting in November, as you'll see from the work plan, which is quite solidly packed. So we probably won't be able to include many more items in that. But for January, we'll want to come back to the board on the health and wellbeing strategy. But we could certainly facilitate incorporating these items and the items that have been suggested today in the January meeting on the forward planner.
Sounds good to me. Has anyone got any other suggestions of items that they would like to come on? No? Taking that for mass consent. Very good. Well, I think having an extra health and wellbeing board has been very helpful in terms of shrinking the agenda down to a more manageable chunk. Quite a light and breezy hour and 13 minutes. So everybody, thank you very much for your attendance. Enjoy your days. Roger and Ian, could you please stay on the call with me?
Thank you, Chair.
Thank you.